Okay, there we go. So what I'm going to discuss today is how to set up, and we're going to kind of do what I've kind of put together as a modified liver, MRCP, and pancreas protocol. Now, at clinic sites, they might have a MRI liver protocol, an MRCP protocol, and even a dedicated pancreas protocol. So they might have 3 separate protocols for each of these 3 items. But what I've done in this practical, and even though it looks like it might be a lot, it's kind of a condensed, modified, a little bit of liver, a little bit of MRCP, and a little bit of pancreas, kind of all molded into one. So the case that we're going to pick is the Owens abdomen liver. And then, thank you. Okay. There we go. And then you're going to see underneath the hospital tab, under the abdomen file, there is a liver protocol, there is an MRCP protocol. This is that combination liver, MRC, pancreas protocol that you're going to want to go ahead and pull over. But you know, there is like a dedicated liver, and then there's also a dedicated MRCP, and with that we'll include, you know, some of the pancreas images as well. But our survey is going to be a breath hold, and that's one thing I want you to start looking at. You know, I've told you about the little red dots that tells you that it's a high SAR scan. If you look right next to it and I hover over it, you'll see that that's a breath hold. So you need to instruct your patient to hold their breath. Down here, this is not a breath hold, so therefore it's going to then use either a navigator pulse or that respiratory bellows. Again, you'll see breath holds here. Our diffusion will have a navigator pulse. Our 3D MRCP series will have a navigator pulse. And then our last one, our breath holds. So these will kind of give you indications of, do I tell the patient to hold their breath, or are they free breathing, which means they're just breathing normally. So this very first picture, what I'm going to do is make sure I have my correct coil, and it's going to be my Sense XL coil, and I'm going to go ahead and make sure all the elements are turned on. Okay, I don't want just the top elements or just the low. I want all of these elements turned on. I'm going to proceed. Now, I'm not going to start it yet. See down here once we hit start, because I need to tell my patient to hold their breath. And that's what's going to be the maybe hardest part for you to understand with this practical, is holding your breath, communicating with that patient is crucial. So I cannot start my scan until I tell my patient to hold their breath. So what I'm going to do is I'm going to say, okay, Cindy, I need you to take a breath in, blow that breath out, and hold it. Then I will start taking my pictures. Then I can say, okay, Cindy, you can breathe. My 3-plane pilot then pops up. I have a coronal, I have an axial, and I have a sagittal. Okay? Now, the very next survey that I'm going to do is just to set up my navigator pulse. Okay? So what I can do is, if I'm going to do a liver, I can do my axial straight through the liver. It's best to take a sagittal then right through the very, where you got the very highest dome of the liver. Okay, and then you can take your coronal to go right through the coronal here, through the liver itself as well. Now what you need to concentrate on this here is this box here. I'm going to go ahead and click on it here. Okay, this is my navigator box. So I want to put this where it's 1/3 I'm sorry, 2/3 in the liver and 1/3 in the lung field. Now notice if I bring it over slightly, I can see it on my sagittal viewport. Because what I want to do on the sagittal is I want to go ahead and look at the entire dome of the liver and position this appropriately. Then I can go back over here and I'm going to move it to where it's at the very top. Yeah, I can almost draw a line, and that's about the top of the mountain, right? So again, 2/3 liver, 1/3 lung field. It's going to go ahead and give me another localizer. It's only going to be 33 seconds. And it's going to go ahead and just do a survey with that patient breathing. I'm going to proceed. And then I can say, okay, Cindy, for this next set, just breathe normally. And start. If I look at your number 4 on your protocol sheet, I'm going to set up for a coronal T2. Coronal turbospinal T2. It is free breathing, which means they're going to breathe normally. So I'm going to go ahead and open this up. Notice my navigator box should pop up to where I just positioned it prior to. Okay? If you don't like it, if you want to make sure it's in the right spot, again, you can move it there. But again, 2/3 in the liver, 1/3 in the lung field. You need to cover the entire liver. Okay? So I'm going to go ahead and get in the best axial I can, which is here. I'm going to look at my field of view. And does it look like I have a good field of view of this entire liver? Notice that because this is a coronal, the only 2 options that I have for fold over or for phase direction is going to be right to left or foot to head. Well, I know that I'm going to definitely want right to left, right? I want this heart motion here to go in this direction. I do not want it to come down into my abdomen here. I want it to stay in this chest field up top. And this is why it's important to have your patient's arms above their head so you don't have to worry about wrap. Okay? So right to left here, it looks pretty good. If you feel like you could do, it's at 375. Could you do a 350? Okay, now you're right on the edge here, right? I wouldn't go any more than that because of the fact you are at the edges right to left of that skin. Head to foot. How much do I cover head to foot? Well, you know, generally speaking, we don't want our field of view here to be too small. Let's say that. Okay? You know, you could say I just want the liver. But many times we want to get as much of this upper abdomen as we can. So I'm going to go ahead and leave my foot to head. Let me try a 350 here. If I get just to the very tops of these iliac crest, that's pretty good. Maybe some sites will say, let's go down and even get more of the pelvic region in. Okay? But I'm going to go ahead and pick, I'm going to go back. It's given me a conflict. So I went to a 375 right to left and a 350 foot to head. Field of view looks, this would be fine. Our book talks about doing our slice thickness for the liver. I'm going to pull it up here. when we're doing coronals, they like to use slice thicknesses between 5, it looks like between 5 to maybe, 6 slice thickness. So if I would go to a slice thickness of 5, okay? And then if I would go ahead and add some more slices. You have to kind of look, am I going to get all of the liver in these pictures? I can look at my sagittal and I can say, you know what, I know the liver's not going to go, back any farther than here. I'm actually almost to the fat part here, but maybe is the belly going to get bigger as you go down? Maybe, maybe not. So I'll add a couple slices to be sure. So I have 32 slices. I have a thickness of 5. And let's see, and my gap is at 1. And that looks pretty good. As far as my TR and TE goes, I need to make sure that I am going to get a T2 weighted image. And with a TR of 425, I am not going to get a T2 weighted image, am I? So I'm going to turn this to, looks like it's going to ask me to do a range here. So if I would go to a 2500 TR, and I have a TE of 80, that will give me the T2 weighting that I want. Now we're going to go to this turbo factor of 64, and if I bring it down to that 23 range, look what it does to my time. It jumps it up to 16 minutes. Well, this is a kind of a specialized navigator triggered pulse sequence. So we're going to leave this TSE at 64 because notice it's going to then keep my time at around 4.5 to 5 minutes. And for a free breathing T2 weighted scan, 4 to 5 minutes is pretty normal, okay? So again, don't worry about the turbo factor on this one. Only look at the TR and the TE. I have a 2500 TR and I have an 80 TE. That will give me bright fluid on my pictures, and that's what I want, okay? So I like my field of view. I like my number of slices. I like my slice thickness. I like my TR and my TE. This looks pretty good. I'm going to then just tell my patient, I can proceed it, and I can say, Cindy, this next set's going to take about 5 minutes. I just want you to breathe normally. And then I can start. The next number 5 is going to go ahead and be this balanced turbo field echo. And I did a slash and I called it a Fiesta because that's what GE calls it. And Siemens calls it a true FISP. Okay, basically this axial balanced turbo field echo is another type of a T2 weighted image. It'll give me bright fluid, but this time it's a breath hold because notice I actually have this breath hold icon. So I'm going to go ahead and double click it. I'm going to go ahead and do this in the axial plane, and I did a better coronal. So now I can go ahead and I can go to scan. There's a bunch of scans in here. But I can go to scan number 4 here. Let me just even think about if it's, yeah. We're going to do scan 4.1. I don't think they have another coronal in here for us to pick. But 4.1, and if I go ahead and window it, is actually a T2 coronal of the liver. So I can pull this up. I'm going to, again, look at my field of view. So I am going to go ahead and position my field of view as a rectangle because I am longer right to left than I am A to P. This has a field of view of 375 right to left, and from A to P of 299, or let's say 300. Notice it's real important to look at that A to P, because if I would even go to a 240, it drops time down. It's a time savings, right? But you have to understand that we want to have a little bit of air because we don't know how that abdomen is going to move as we have them hold their breath, right? So we do want a little bit of air. GE always told us about 3 to 4 millimeters of air around that entire abdomen. So a field of view of 375 by around 300 looks good. I'm going to then make sure that I get from the above the liver superiorly all the way through the liver inferiorly. And the slice thickness that I'm going to use, I can actually go up a little bit. So if I look at my book here, my flip book, as it talks about abdominal work, when they're doing axials, many times they'll go to an 8 millimeter thickness. You can even do like there's a 7 millimeter thickness because this is a breath hole. I can't go too thin because with this many slices, my time will be way too high. So I have a 7 millimeter thickness and I have a gap of 1. Okay, so we can page through here and say, am I going to get all of the liver? Because I'm way, here's the very tip here. So I might want to add maybe 3 slices just to be sure that as that patient's taking a breath in and blowing it out, that I'm going to not miss any of this liver right here. Okay, so I have 30 slices here. You do not, because this is a specialized balanced turbo field echo here. I just want you to look at the TR and the TE values. Do not change any of these values. But if I look at my contrast page, notice that I have a TR over here. The TR is set to shortest and the TE is set to shortest. The actual TR is 3.1 milliseconds. The actual TE is 1.5. So notice how these are extremely short. It is a specialized protocol that will give us this bright fluid, okay? So do not change any of, under the contrast tab, do not change any of this. Now, right now this tells me it's 19 seconds long. I'm going to go back to my geometry page and I'm going to say, what is my sense factor? I have it turned on. I have a P reduction factor of 1.4. Okay, and that's what I'm asking you. What is it? What is that P reduction factor? If I would go up to 1.5, it saved me a second. If I go up to 1.6, it saved me another second. Notice how the time changes. I would say that anything under 20 seconds is a pretty good time for a breath hold. Now, on these brand new scanners out there, you know, we are now capable to be doing breath holds around 12 seconds, 13 seconds. On average, though, what I see is breath holds around this 16 to 20-second range, okay? So you just tell me what P reduction factor you are using. Is it, if you're going to stick at a 1.4, it's going to take 19 seconds. If you feel you have a patient in there that cannot hold their breath for that long, you might want to go up to 1.9 and drop it down to 14 seconds. Okay, but you tell me what you want. If you like how everything's set up here, because I'm not changing any of the TR and TE, right? I'm going to click proceed, but again, don't start it because I have to tell Cindy, okay, Cindy, this next set is going to be with you holding your breath, okay? It's going to take about 14 seconds. So right now I need you to take a breath in, below that breath out, and hold it. And I'm going to start taking my pictures then. She's going to hold her breath for 14 seconds, and then you can say, okay, Cindy, right now I need you to breathe normally, and let her breathe. Number 6 is the in and out of phase, okay? So what I'm going to do is set up number 6 exactly like I set up number 5 prior to that. So I'm going to do a 7 millimeter thickness. It was at a 1 gap. I think I had what? Was it 30 slices? Yes. I'm going to go to 30 slices. My field of view was right to left, 375. A to P was around 300. That looks good. This actually has rest slabs built into it. Can anybody tell me, is this a breath hold? What do you think? Anybody want to chime in? Yes? No? It is a breath hold. It is a breath hold. Only because, and it's probably hard for you to see, but right here is the little icon that says it's a breath hold. Okay? It is hard to see, yes. So once you have this position, and you want to make sure again that you get the entire liver on here, and if you feel like you need to page through, you have these nice coronals where you can page through. Okay? So once you feel like you got the entire liver on, your parameters are pretty set. What I'm asking you then is to look at these echoes. So I'm going to go to my contrast page. I am not going to change any of my TR because that TR is at 175. It's a gradient echo scan. So therefore it's going to have a very low TR anyway for this breath hold. But notice how I have an out of phase TE of 2.3 and an in phase TE of 4.6. And then you need to tell me, is that what I want? Well, this is a 1.5 Tesla magnet. So you need to tell me, is that the TE that I need for this particular case? Okay? If you like those, then you are ready to scan. I'm just asking you the question of what does the out of phase echo do? And I want you to be able to tell me then the out of phase will drop the signal of fat, because we are looking at water and fat when they are out of phase with each other. So the out of phase image will drop the signal of fat. So therefore I can tell then if there is any lesion, is that lesion Does that contain any kind of a fat component to it? That will give that radiologist that information. Okay, that's all you got to do is tell me that. So, I want you to notice that it is 38 seconds long. Wow, that is too long for your patient to hold their breath. But it's done in 2 packages. So therefore, if I look at the scan time per breath hold, it's only 19 seconds. So I need to have them hold their breath twice. So what I'll do is I'm going to proceed, and I'm not going to start it yet, but I'm going to say, okay, Cindy, this next set I need you to hold your breath again, and we're going to do this in 2 steps. I need you to take a breath in, blow your breath out, and hold it. I'm going to start it, and then you can say go ahead and breathe, and we're going to do that again. I need you to take a breath in, blow your breath out, and hold it again. And I'm going to start it again. Go ahead and breathe. Again, this is what's going to be confusing, is understanding this communication of talking to your patient. But do you stop the scan? No. It'll automatically stop because after 19 seconds, it's done. Okay, so you don't have to stop it. But what this makes you aware of is, what are you scanning? What are you doing? Oh, okay, I need to talk to my patient. I need them to hold their breath. Or, okay, no, this is a navigator or respiratory trigger. They don't need to hold their breath. They just need to breathe normally. So it forces you to critically think, what are you scanning? Okay? So, we got number 6 done. We're going to skip over this here, because all of this here we are going to do when we are scanning a kidney next week. So even though we still do this for livers, we're going to actually put this component of the protocol into the kidney practical. Okay, so we're not going to set this up. We will, though, set up a diffusion, and I'm going to go ahead and make sure that my field of view is appropriate. And again, you're going to keep your field of view pretty standard. We can go 375 right to left and a 300 A to P. That looks pretty good. Okay. Now, the slice thickness is 7 at a 1 gap. Should we change this to a 1 gap? And we had 30 slices on all of our other axials. Let's just keep this consistent, okay? Because radiologists then can look at a T2 axial and an in and out of phase axial and our diffusion axials, and they're pretty much all at the exact same slices, okay? Now, this does have a volume box that you can go ahead and just position right over skin to skin, just to alleviate as much air as possible here. But the most important thing I really want you to look at here is under the contrast page, the B values. And remember, we looked at these B values underneath this diffusion mode, and it's NR, number of B factors. There are 3 B factors. And if I click on this little arrow, it'll tell me that I have a B factor of 0, which technically is just a standard T2 weighted scan or T2 weighted looking image, okay? So a B factor of 0, 300, and 600. Do you need to change it? No. But I want you to recognize where it's at. Because if a radiologist says, you know what, I don't like the 300 and 600, give me 400 and 800. Or give me a 250 and a 500. Then at least you know where to locate it. okay? But I want you to be able to tell me how many B factors are there and what are they? Because if I needed to do 4, then I could go ahead and add a B factor, a 4th B factor here, okay? So many of this protocol, you're just finding things. And I'm telling you, even though you don't think you can get this done in 25 minutes, if you practice and if you get this down to, I know exactly how I want to run this, you can get it done because it's happened in the past. Other students have done it, but it takes practice, okay? It's 4 minutes long. This is a navigator. And so technically what I want to make sure then is trying to find that tab of the navigator pulse. So this says that it's a navigator respiratory comp. And it should still give us that box. I'm trying to figure out why it doesn't here on here. There it is. So if I page through here, I can see where this navigator box pops up. So then I'm going to go ahead and just again put it where I want it at the very top of that dome of the liver, 2/3 in the liver, 1/3 in the lung field. It's 4 minutes, and I'm going to say, okay, Cindy, I'm going to proceed it and say this is going to take about 4 minutes. Just breathe normally and start. Now, the 3D here of the MRCP is where I'm looking at my pancreas. So what I'm going to need to do in my middle viewport is to put a better axial up there. And it's going to be in series 5. This is T2. I got bright CSF. And I'm going to look for my pancreas. So if I go to the center as I'm paging through here, when you see this line here, and if you follow it as I'm paging through, you can see this in the middle here. I know my pancreas is pretty much in the center of my abdomen. That is your duct of Wirsung. That is your pancreatic duct. So therefore, I know that as I slice through these, you're not going to get the pancreas many times just all laid out in one slice. You almost have to follow it, okay? So once I see where that pancreas is located, and I keep slicing through here, I know then that this is going to be where my pancreatic head is located. I'm going to slice back, and I can see that this is the body of my pancreas. All you need to do is to angle with the body of that pancreas, okay? Your field of view that you want to pick, I'm telling you, you don't even have to change any of these parameters. Just set this up over the body of the pancreas, because what I am wanting to look at is this biliary tree. And I will catch it on these images here. So set it up like this. It's going to be about a 3-minute scan. I see my navigator box. So if my navigator box is on, that means it's free breathing, right? I'm going to proceed and tell Cindy, okay, Cindy, this next set's about 3 minutes. Just breathe normally. And I'm going to scan it. The very last set is a Radial Mrcp. It is a breath hold. So I'm going to open it up. Notice you have 1, 2, 3, 4, 5 slices here. Okay? As far as your field of view goes, you can go ahead and just put this field of view about right where you're going to see this entire liver and that biliary tree. You can go ahead and take this volume box, and just put it right where that pancreatic head's located. And then you can turn it off so it's not bothering you. But what I'm asking you to do is to set up 3 slabs. So if I go to my geometry and it has 5 slices, I'm going to change it to 3. Then what I'm going to change is, if I take these, I can go ahead and position these any way I want. Okay? If I look at the radial angle here, right now I have about a 21-degree angle between them all. Well, let me go ahead and do a 45-degree angle. What that will give me then is, if I go ahead and swing this around, I want you to get me a slice that goes straight across at 45 degrees, and then also at a perpendicular to that pancreatic head, okay? And many times what you can do as you page through these, right here's part of your gallbladder, so you can kind of try to position this to go right where this gallbladder lies, okay? And notice, even though this is a 1 slice, if I look under the geometry tab of the thickness here, it'll tell you that it is 40 millimeters thick. So this is a very thick slice. So you're going to actually get a slice about, if you look at my 2 fingers, you're going to get a thick slice this way. So I'm going doing a thick slice this way, a thick slice this way, and a thick slice that way. And then what it's going to allow me to do is, if you look at this little structure here on the little tips info here on that corner, and you can see it better when you're in lab, you know, basically we're going to look at the gallbladder and that common bile duct and the pancreatic duct in 3 different turns. We're going to look at them straight on, we're going to turn the body at a 45-degree angle, and then we're going to look at it more in the sagittal plane. But this is how I want you to set up this last set. All you have to do, you don't have to change any of the parameters except change it to 3 slices, change your radial angle to 45, okay? Make sure you set it up appropriately. You're going to have to tell me, where is that pancreatic head located? I want you to be able to see it. I want you to say you can see part of the gallbladder here. And these are going to be a breath hold. It's going to take 24 seconds, which is going to be kind of long, but it'll be okay. Actually, what is going to happen is our scan time, because it's 3 slices, 3 divided by 24, each slice is 8 seconds long. So what we'll then do is we'll hit proceed, and we'll say, okay, Cindy, I just got 3 more sets to take. Each set only takes about 8 seconds, and I'm going to have you hold your breath for each. I need you to take a breath in, blow your breath out, and hold it. Start. Breathe. Take another breath in, blow your breath out, and hold it. Start. Breathe. And then the last one here again, take a breath in, blow your breath out, and hold it. Start. Go ahead and breathe. So you've now taken all 3 of these sets, all 3 of these slices, and then you'd be able to view them on your scanner. Now I'm going to pull this back up because different places will do this radial and maybe 30 different ways. Currently, we do 12 slices at probably, let me change this to like a 15 degrees. And notice that it almost makes a complete circle. So where I work at, we put this middle of this radius here, okay? Think about this as a radial here. We put it right at the head of the pancreas. And then we can go ahead and start with our first slice. And notice these are numbered. You might not be able to see it as well at home, but you can tell where your first slice is at, okay? And we'll just do that as a straight coronal. And then we just take 12 slices, and basically what the doctor sees is a complete rotation of that common bile duct, pancreatic duct, and gallbladder. Okay? Now, is it a lot of breath holds? It sure is. It's 12 slices. It's going to take about a minute and a half at 8 seconds each. So, you know, that's where their, you know, pros and cons are, you know, of how many slices, how many breath holds do you want to be talking to your patient, you know, with. So, but I'm just showing you a different way that you might see out in the field. I'm only asking you to set up 3. Notice maybe other places that you'll go to, you might actually set up more in that radial MRCP pulse sequence here. Okay? And just to let you know, that's down below here that you couldn't really see. But it was the diffusion was here. The 3D MRCP was here. And then below that is the radial MRCP here. Okay? So, like I said, even though this might seem like a lengthy protocol, you're not changing hardly any parameters. Once you get your field of view and you get your slice thickness and you get your number of slices set, you're going to use that on all of your axials. Okay? So basically that's just plugging them in, setting it up over that liver, and you're going. Now at the very end, I want to make sure we're going to go through these series here. So I'm going to plug them up here, or pull them up. I'm going to go to series 4, which is my T2 coronal. I know it's T2 because, and it's a fat sat. If you look over here, it's T2 weighted spare coronal. They did utilize sense, but I want you to tell me, where is that common bile duct? And where is the pancreatic duct? And where is the duodenum? Okay, so you need to page through here and tell me where it's at. Well, what's kind of neat is this gets a great picture of the duodenum. Do you see where it makes the C? Right here is this nice letter C. That is your duodenum. I know that the pancreatic head sits in the duodenum, and right here is the pancreatic duct. If I go to the very next slice, again, here's part of this C, that's the duodenum. I could see part of the pancreatic duct. I've seen it better here. But if I see this pancreatic duct here, I know that the common bile duct converges here. So right here at this convergence is that ampulla of Vater. And you can actually see how it empties into the duodenum here. So that's all you need to pick out on this particular series. We're going to go to series 3. 3.1. And this is just a traditional T2. This is not a fat sat. It's just a T2 weighted scan. And I want you to pick out the portal vein. So if I page through here, okay, well, I know that over here is the aorta, and then I know that the vessel to the right's got to be my inferior vena cava, and if I look here, here's part of it, and right here's the other part. So you can really see how this vein goes into the liver. That's the portal vein. Then I just want you to pull out the left lobe of the liver. Well, I know the left lobe is going to be the most anterior lobe, so that's going to be over here. And then your right lobe is going to be the bigger lobe over here. Okay? Can almost kind of see, you know, like almost, you can't really pull out the ligament per se, but I know that the left lobe's here and the right lobe's over here. And you're done there. Let's go to series 6. Okay, this is a T2 spare, so it's a fat sat. And I should be able to look at this and know it's a fat sat because my fat is suppressed here. Now I'm just telling you, tell me where the pancreas is at. So I'm going to page through here and start to look to see where can I see that little worm or snake type of thing, and I can see part of my duct of Wirsong. So here's the tail, and then I'm just going to have to follow it on my slices. I can see here's part of the pancreatic duct. That's the body. And then as I go down farther, I know that this is going to be where my pancreatic head is located. Okay, and then we're starting to get into the duodenum here. And that common bile duct is really going to be in this area where this duodenum's at, probably right here. You can see here's that pancreatic head. Here's a little bit of the gallbladder, and you can see how there's something here coming down. So I'm going to call this and this here as your common bile duct. Okay? Number 7, this is my M. Dixon. If I look up here, this is my M. Dixon. This is where I am going to get all 4 phases: water, fat, in phase and out of phase. And if I have 4 on 1 here, but I'm going to actually put like 4 on 5. Okay? So if I look at these slices here, and if you start paging down, notice how it starts to change in your pictures here. You're going to have to page down through all of these images, and that's a lot of images. But notice how it starts to change here. Page through all of these. That's a lot of images. This is what radiologists have to do. Notice how it changes here again. I'm back to slice 1. There's 131 slices. This is a volume of the entire liver, probably at 1 millimeter each. So as I go through here, here is another image, or another set, another phase. And then here is another phase here. You need to tell me, and we'll discuss this in our lab, you need to tell me where is the in phase series and where is the out of phase series. And you should be able to look at these images just by the signal that it's representing and tell me what's in phase, what's out of phase, and what is my water only image. And I'll give you the hint that the very first one that comes up, well, that's my water only because my fat is dark. All of the little fat that's within the abdomen here is dark. So that means it's my water only image. And then as you proceed through all of these sets, you're going to then have to pick out the in phase and the out of phase. And then it'll be easy to pick out the fat only, because all you're going to see is the fat around the outside and the fat within the center of the abdomen around your organs and stuff. And that's how you scan an abdomen. What's your thoughts? Are you guys confused at all on any of this?